Alright everyone, let's talk about Simman stations here. I will start with an approach first and then we'll use the same approach in every single Simman, and it should be very simple here. Just to give you the heads up, so in every station and in every mind map there will be point number 3 and point number 4. Okay, this will not be part of the station, but that will give you the basics that we need to do in every station, and it will give you the guidelines for this particular scenario. For example, asthma guidelines, anaphylaxis guidelines, acute limb ischemia guidelines. So once you know the guidelines, you don't need to memorize anything, you don't need to remember the script or the notes or the mind map. You have the guideline, you have the basics, you are good to go. So let's talk about them first. What is the first fact with Simman? The first fact with Simman that when you are dealing with a Simman, the monitor should be your friend. So during the whole 8 minutes, your eyes should check the monitor from time to time. So make sure you are aware of that. Okay. Second thing, you should be very flexible. So if you are taking history and the patient is deteriorating, you don't have to stick with the history. You should be flexible and go for assessment or examination and manage, and then you can come back to history again. Okay, so you should be flexible with Simman because it's an acute station. So the fact that you should take history when the patient is well. So if he's fine, talking to you, vitals are stable, keep asking questions and take history. And when you are doing that, the second fact is that you should engage the Simman or the patient. Okay, so with everything you do, you should verbalize your thoughts with the Simman or with the nurse if you have a nurse in the cubicle, or with the examiner. And the fact that you share your thoughts is a strong fact. You get marks when you share your thoughts. For example, you say, I'm assessing my patient breathing, I can see his oxygen is dropping, so I'm going to give him some oxygen, high flow oxygen, 15 liters per minute. You are sharing your thoughts, or you can talk to the Simman if he is communicating with you. Okay, Mr. Jack, I can see your oxygen in your blood is dropping, so I will be giving you some oxygen to ease your breathing. So then the examiner will know that you know how to manage him. Okay, the third and the last fact that in Simman, when he is unwell or when we do assessment, we follow A, B, C, D, E approach, and you all are very good with that, and I will go through it today as well. And with A, B, C, D approach, you should know the style that we will follow today, which is triple A style. What is the triple A style? First, A is assessment. So you assess A, you assess P, you assess C, you assess D, you assess E. Okay, so you do assessment first. When you find something not normal, you do an action. The second A for an action. Okay, for example, I find that breathing is not very good. Saturation is low and respiratory rate maybe is high. So I will do an action. I will give an oxygen to my patient. And then I will go to the third A, which is assessment again, to see that my action is working. So I will look at the monitor again to see saturation. Is it getting better? I will ask my patient, how are you feeling now, Mr. Jack? Doctor, I feel much better. Okay, so these are the basics. Monitor, okay, is your friend. You should be flexible. You will be taking history when the patient is well, but if he is not well, you will go for assessment A, B, C, D, E. With your assessment, you should know the style. I assess something. If I find it abnormal, I will do an action, second A. If I do an action, I will need to do the third A, which is assessment again, to make sure my action is working. If you know these basic facts, you will be totally fine with any station. So let's start the Simman station or the Simman structure or approach. So the Simman will be like a similar man coming with a presenting complaint. That can be, for example, problem with breathing, like that, 2 cases. Okay, maybe dizziness or feeling unwell, like being bleeding or having sepsis. Okay, or maybe unconscious or confused, like hypoglycemia. Okay, so anyway, at the end of the day, he is coming with a presenting complaint. Either he is telling it to you, or you know it from the task, or you know it from the nurse if there is a nurse. So still, we are following the same structure as we do every time. If someone has a presenting complaint, what I always do, I need to listen to it. I need to explore the presenting complaint with an open question like usual. Can you tell me more about that? Okay, Udibara, for any symptoms or Socrates for pain. You don't have to do all Odibara or Socrates, but just see what is relevant for you. If it's short and suppressed, tell me, Mr. Jack, how long this has been happening for. Okay, so just ask what you think is relevant here. And with starting with an open question or exploring the presenting complaint, as I told you, monitor will be my friend from minute 1. So I will look at the monitor. If the patient is stable, can talk to me, the monitor shows that the vitals are reasonably stable, you will go ahead and complete the station as a normal station, not as a Simman station. What do I mean by that? By taking history data gathering, okay, presenting complaint, red flags, general history, and then examination, and then management as usual. Because the patient is stable in the monitor and the patient is talking to you. That's one possibility. Like for example, the station of pulmonary embolism. The Simman will be relatively stable. So you can talk to him, take history, examine as pulmonary embolism station in the mind maps, and manage as the mind map in the respiratory section. Okay, or for example, atrial fibrillation patient, he will be stable as well, so you can manage with history, examination, and management here. This is the first possibility. What is the second possibility? Second possibility, that I may have a talking Simman. Okay, so he's talking to me, but when I look at the monitor, he can give me history, but when I look at the monitor, he is not vitally stable. So the monitor is not showing vitals are stable. So what will I do? I will talk to the patient quickly when he is well, and once I see the vitals are unstable, I will go for my second step, which is assessment, A, B, C, D, E, and I will follow the style of AAA. If I find something abnormal in assessment, I will do an action, and then I will do reassessment again. This is the second possibility. So the first possibility, talking Simman and stable, that will be normal station as clinical station. Second possibility is talking Simman but vitals are not stable, or monitor are not showing stable vitals. So I will go for assessment and follow the style of AAA. And the third possibility is that the patient is not talking and as well vitals are not stable. So that will be unconscious patient. What will I do in that case? I will do the BLS, okay, basic life support. Okay, how will you do that? You will look, listen, and feel for respiration or for breathing. And if the patient is breathing, it will be similar to the previous scenario. You will do A, B, C, D, E assessment and go with the style. For example, in hypoglycemia case, the Simman will not be talking, but he will be breathing. So you will go to style number 2. And if the Simman is not talking and vitals are not stable, and when I do look, listen, and feel, there is no breathing sound, that will be the basic life support, which you will do chest compressions or you will check for DNA CPR, but this case is not in BLAB 2. Okay, this you can have in the resuscitation training, but not in the BLAB 2. Okay, so we have 3 scenarios only, okay, or 3 possibilities here. Stable and talking Simman, that will be normal station. Okay, talking Simman but he is not stable, so I will assess with A, B, C, D, E approach. Or maybe not talking Simman, not stable but he's breathing, I will follow A, B, C, D, E approach as well with the AAA style. So this is just a general knowledge about Simman stations here, but don't worry, let's give you the structures that we can follow every time. So history wise, I will start with presenting complaint. How can I help you today, Mr. Jack? Doctor, I feel very short of breath. Can you tell me more about that? And I will look at the monitor at the same time. If the monitor shows that his vitals are not right, so I will start with assessing him. I will start with assessing number A. So my patient is talking, so I will assume that airway is patent. You can tell that to the examiner, to the nurse. My patient is talking, so the airway is patent. What is the second possibility? The patient might not be talking. He might be giving you abnormal sounds like gargling sounds, snoring, stridor. For example, in an anaphylaxis case, what would you do for that? If something abnormal, I will do an action, I will do an assessment again. So I will look at the airway, head tilt and then chin lift, and if I find any secretions, I will do suction. If I find a foreign body, I will remove it. If I find lips swelling or tongue swelling, I will think about anaphylaxis and manage. But that will not usually happen in BLAB 2. You will find the patient usually talking, so you will say airway is patent. And when you are assessing the airway, you are looking at the monitor. If you find oxygen is low, saturation is low, less than 94 for example, you will give oxygen. I can see, Mr. Jack, that your oxygen in your blood is dropping, so I will be giving you oxygen to ease your breathing. And then you can tell the examiner or the nurse, I would like to give my patient 15 liters of oxygen per minute via a non-rebreathing mask. Okay, if the patient has a smoker cough, so you will use the Venturi mask and you will go with low flow oxygen. Okay, we'll talk about that in details in the relative stations here. And then once you make sure that this airway is done, you assess airway is patent, oxygen is fine, or if oxygen is low, you are giving oxygen, you are fine. Now you will go to step number 2, assessing for breathing. What should I do in breathing? I will start with examining 3 things: trachea, chest, and I will look at the respiratory rate and saturation again. So trachea, I will put my 3 fingers on the trachea and you will find the trachea is central. What can happen in the trachea? But that doesn't come as well. If the trachea is shifted to one side, you will think about tension pneumothorax in the other side. And what will you do if there is tension pneumothorax? What will be your action and the assessment again? Your action will be needle decompression, and your assessment again that the patient breathing will be much better. But that doesn't come. Okay, so I will assess for trachea. Examiner will tell you, doctor, trachea is central. Or you can put your 3 fingers on the trachea and you can say, I can see the trachea is central. And then, Mr. Jack, I would like to examine your chest to find what is the cause for your breathing difficulties. And that will include me undressing you above the waist. Will that be okay? So you can then examine the chest, examination of the chest, inspection, palpation, percussion, and auscultation. Okay, so when you inspect the chest, what can you see? I'll give you an insight about all the cases. Okay, so when you inspect the chest, you can find maybe chest recessions or difficulty of breathing. So you might think about maybe asthma flare. This might be, for example, anaphylaxis, might be sepsis because of a chest infection. So you can see in inspection, for example, difficulty of breathing. What else can you see in inspection? You can see some rashes. Okay, and what do you think in that case? That can be the anaphylaxis case then. What should I do in that case? I will think my patient has rashes on his chest. I think this is an allergic reaction to something, so I would like to stop any medication or transfusion going on, because that can be a possible cause for the allergy that's happening. So this will be my action, and then I will look at the monitor to make sure this action is giving me some assessment back. And I will check the respiratory rate. I will not count it by myself, but you can look at the monitor and you will find it there. Okay, and you can ask the nurse to do it for you if it's not on the monitor. So we said about inspection of the chest. Usually palpation and the percussion not very important. You can skip them, or the examiner will tell you, doctor, they are fine. And if you like to do them, please don't waste a lot of time. Palpation, just to check for chest expansion. Percussion, do just 3 or 4 and go ahead for auscultation. So the most important thing in a chest examination is inspection and auscultation. What can happen in auscultation? You can hear 2 abnormal sounds here. The first one that you can hear is the wheeze sound. And if you hear wheeze sound, what will be your action? I'll give a nebulizer to ease the breathing. I can give salbutamol nebulizer to ease the breathing. Okay, what if I hear crepitation? So that might mean some fluid in the lung, so I will think about heart failure and I will give water injection or furosemide for the patient here. Okay, heart failure, I think it doesn't come as well. So wheezes is what you possibly can hear, or the examiner can tell you, doctor, there are wheezes in the chest. In that case, you will say, I would like to give my patient salbutamol nebulizer 0.5 milligram via nebulizer through the oxygen. Okay, so then you can give the nebulizer, and then when you give something, you will reassess again. You look at the saturation and the respiratory rate, and you'll find them getting better. If not, you can try the abratropium nebulizer. Don't worry about that. We'll go about the guidelines in every single case. So this would be my second step in breathing. My third step in breathing, if breathing was not normal and I needed to do an action, I will finish the B part by ordering an X-ray and arterial blood gas for the patient. I will order an X-ray for my patient, and I will order, or I will request for arterial blood gas sample. Or you can tell the nurse if there is a nurse with you in the station. That will be number B in assessment. Okay, then I will go to number C in assessment, which is circulation. The same as number B, I will start with examining a few things. I will do an action. I will request something at the end. What will I examine? I will look at the monitor to look at the blood pressure and heart rate. Okay, what can I find? You can find normal, that should be fine. Abnormal, what you can find for BLAB2, low blood pressure and high heart rate. which means hypovolemia, and what action will I do to correct that? I will give IV fluids. And then what will be the reassessment? I will look at the blood pressure again. What will happen? It will come back higher or maybe back to normal. So examination of circulation will include looking at the monitor for blood pressure and heart rate, checking capillary refill, because if it's prolonged that can mean dehydration or hypovolemia, and looking for any external site of bleeding. Okay, once you do this assessment, you will do an action. I would like to insert 2 wide bore cannulas for my patient. So you do a cannulation for circulation. And why do you do cannula? You do cannula for 2 things: to take and to give. To take bloods, so you can send the blood for investigation to know the cause for the problem the Simman having. Okay, is it sepsis, for example? Is it because of problem with electrolytes, or what is happening with the patient? So you will take bloods, and we will mention the name of bloods in the relative stations. And what will I give in the cannula? I will give IV fluids if blood pressure was low. I will give antibiotics if it was a sepsis case. I will give, for example, IV hydrocortisone or IV antihistamine if I think about anaphylaxis. Okay, and then if I find the problems with the circulation, I will finish by requesting, I would like to request an ECG or a 12 leads ECG for my patient. Okay, after I do the circulation part by following the style A and A and A, I will do the D part. D for disability. First thing in disability is checking the patient consciousness. You can follow the AVPU or Glasgow Coma Scale. AVPU will be more easy for you because of time restraint. A for alert, V if he's only responding to verbal, P if he's only responding to pain, U if he is unresponsive. So my patient is alert, he is talking to me. Okay, and then in disability you will check blood sugars, PMs, okay, because if the patient is hypoglycemia, you will know here that he's hypoglycemic. And what should I do in that case? I will give dextrose, the action. What will I do after the action? I will do assessment again. Patient is gaining consciousness or the blood sugar is getting better. What else I can do in disability? I will check temperature. What can happen here? High temperature. What should I do as an action? I will give IV paracetamol. What should I do after the action? Reassessment. Temperature will come back better after some time, or the patient will feel better. Yeah. And they check pupils, but you'll not need to do that in BLAB 2 cases unless if they bring, for example, morphine poisoning. Okay, and number 5, exposure. Okay, E for exposure. What I'm exposing for? I'm exposing to look at the abdomen, because I didn't examine the abdomen, looking at the legs, and when I look at the legs, I will make sure to examine the pulses in the leg, because I have a case for critical limb ischemia. And as well, I will look at the cuffs of the leg. They might be tender or swollen because of DVT or pulmonary embolism. And you can do exposure to look at the private area. If this lady was, for example, coming back from delivery and bleeding, so you can have bleeding from vagina or suture in the perineal area. Okay, so you do exposure to look for rashes, in anaphylaxis, bleeding in some cases, and wounds for another cases here. Okay, make sure you look at the lower limb, please. So this is the assessment of any Simman, A, B, C, D, E approach. This is what you do in every one of them, and this what can be abnormal, and if it's abnormal, this is the action that you can do, and if there is an action, you can do reassessment again. I hope you got the point now. So what will I do after that? I will do the management, okay, or I will complete the management. How will I complete the management? If it is with the patient is stable now, I will give him the diagnosis. So Mr. Jack, what you have been complaining of, possibly because of flare of your asthma, okay, and then I will tell him what I have done so far. So we have started you on oxygen to ease your breathing, we have given you some nebulizers or some medication to ease your breathing and to make you feel better, and we have sent some bloods, and we will be waiting for the results and admitting you until you feel better. Okay, if the task is telling you, doctor, hand over the case to your senior, to the examiner, so you will do the handover protocol in the last 2 minutes, SBAR. I think we have done a video about SBAR, and we will talk about it in the relative station. S for situation, B for background, A for assessment, R for recommendation. What will be my second step in finishing the management? I will talk about the workup done, because I stabilized the patient, but I have sent a few investigations to find out the cause. So we have sent an X-ray, arterial blood gases and the bloods to look for the cause for that, and I will inform my senior for reviewing and keeping the patient under observations. Okay, and then once the patient is stable, you can talk about the plan. For example, it's asthma plan or follow-up plan C. So if you listen to this station or to this structure, you can cover any single Simman station. So let's go quickly about it again. Simman stations, okay. History wise, if he's coming with presenting complaint, I need to explore it from the patient if he can talk, from the nurse if it is there. And the monitor is my friend, so I will always keep looking at the monitor. If the monitor is stable, I will keep going with the history, and it will be similar to normal stations. If the monitor showing deterioration, I will need to go to step number 2, which is assessment, and go along with assessment here. Okay. If the patient is talking or the patient is stabilized, so I can continue history. What will be the history? It will be just a quick, brief history. Presenting complaint history, asking about trigger, what was triggering that, Mr. Jack? He may say antibiotic, doctor, or I started having the transfusion and then I felt unwell after that, or maybe I was having my insulin, so you can think about hypoglycemia. Anyway, and then you will finish your presenting complaint by anything else you are complaining of or any other symptoms at all. So that will be the first step as usual. Second step in history as usual is specific closed questions about red flags. For example, if it's coming with shortness of breath, you will think about any chest pain as a red flag or any leg pain or leg swelling as a red flag. Just one quick question here. And then general history as usual, past medical history of similar or of relevant problems, especially COPD if you are giving oxygen, because you will need to give a different oxygen regime. And then use of medication, so you can know what will be your next plan. And any known allergies, because you will be giving different medications during your station. Basics of the Simman, we have gone through them. If you understand the basics and if you know the guidelines, which I will share in every mind map, you should be good to go. Just be aware we follow ABCD approach, and our style is assessment, action, and reassessment again. In the last 2 minutes, we tell the patient the diagnosis, we do summarize what we have done, and we tell him what will be the next step forward. Okay, basics again, monitor is my friend. I always look at the monitor. If it is stable, it's a normal station. If it's going wrong, I will go with A, B, C, D, E. Okay, and whenever the patient is well and talking, I will explore the history and engage him with me all the time. If I do examine something, I will tell him I'm going to examine that. If I'm giving him an oxygen, I will tell him I'm going to give you oxygen, Mr. Jack. If I'm giving him drugs, I will engage him. And if there is a nurse in the cubicle, I will engage her as well and tell her what I'm thinking and what I'm going to do. And when the history is taking, or when I'm taking history, it's only simple history. History of presenting complaint, any other symptoms with that, one question about red flags or differentials, past medical history of relevant, and medication and allergies. Okay, guidelines, I will share them shortly with you. Please remember A, B, C, D, E. A, airway. If he's talking, airway is patent. If he's not talking to you or making a stridor sound or abnormal sound, which will be unlikely for BLAB 2 station, in that case you will do an action, which is clearing the airway and stabilizing it by oropharyngeal or nasopharyngeal tube. When you are examining airway, you look at the monitor. If oxygen is fine, go ahead. If not fine, do an action, give oxygen, reassess, it will come back better. Then go to assess breathing, examine 3 things, assess if anything abnormal, finish with requesting X-ray and ABG. Okay, and examining the chest, don't forget inspection is important, auscultation is important. Okay, and do an action if you find something abnormal and reassess again. Circulation, examine these things, do that action, request that at the end. Disability, you will find in most of the time that the Simman is talking to you, so you can say it's alert, it's checking for blood sugar, if there is a problem correct it and reassess, checking temperature, if there is a problem correct it please. Exposure, to look for the other areas that you haven't seen yet. Abdomen, for example, legs, private area if there was a problem with them, because you are looking for rashes or bleeding or wound. And please finish your station by being structured. Give the Simman or give the nurse or give the examiner, depending on the task, what is asking you to do, give them your diagnosis, your assessment, your plan to move forward. I hope it does make sense. Sorry for the long video, but I needed to put the structure very clearly. it will be more easy in the coming mind maps, because we'll just follow the structure and it will be just filling the point. I hope you found the structure helpful, and if you are keen to see the same structure for the other Simman stations, anaphylaxis, asthma, acute limb ischemia, pulmonary embolism, and hypoglycemia and sepsis, all other Simman stations are in similar mind maps as well, you are very welcome to check the package for that. That is included in the private mind maps package, which includes all cases in mind maps, including Simman in mind maps. Each mind map is similar to the one before. In 5-10 minutes you have everything in a single page, and a lot of other playlists as well, including mechanics for management, mechanics for IBS, and cases simulations and feedback on them, teaching, examination, procedures, everything is included. If you are interested to join, you are very welcome. Text me on that number on WhatsApp or Telegram, or join my groups as you can see in the description for regular free sessions. I wish for you the best and get 12 out of 12.